So for my investigation, I wanted to see the involvement with the endocannabinoid system and sphingolipids with the pathogenesis of Lyme disease. How does it affect the clinical picture? Is that this guy? There we go. Okay. Sorry about that. So what is Lyme disease? Lyme disease is a spirochete-shaped bacteria. It's the same form as syphilis. The bacteria are very similar in shape, morphology. It's gram-negative. The vector that it likes to pass itself on from is ticks. So a lot of times when you get a tick bite, you hear the stereotypical bullseye rash. That is a sign of a Lyme disease infection. So the problem with Lyme disease is it's very hard to diagnose in the beginning. Now, you'll get this flu-like illness, you'll get migrating muscle pains, joint pains, and with the inaccuracy of diagnostics and the unspecificness of the symptoms, it allows for it to, within weeks and months, disseminate throughout the central nervous system in your joints, and that's when it leads to arthritis. It can lead to neuropsychiatric issues, multiple sclerosis-like symptoms. So the issue with Lyme disease right now is, even though people say it's an epidemic, up to 55% of labs failed to identify low levels of antibodies in tests. So if that were you being tested, you would have a false negative. And even within the same lab, and over 21% even missed very high titers. So even if you had a severe infection, there's a chance that they wouldn't identify you as having Lyme disease, which allows it to progress. So they looked to see why this happened, and one of the reasons why this happens is that the antibodies to the Borrelia that should show up on a blood test, they become sequestered inside of complexes. So that allows them not only to evade the immune system, but to evade diagnostics. So with the number of people that already make it to a progressed infection, and the number of people that do, but we don't know because the diagnostics are bad, leads us to need a way to treat those symptoms that result. So it's been associated with a lot of different disease states, one of which is multiple sclerosis. So they did antibody testing to see if it was associated with exposure to the Lyme disease bacteria, Borrelia burgdorferi. 38.5% of multiple sclerosis patients clinically diagnosed had antibodies to Borrelia, which means at least prior exposure, if not current exposure, leading to this disorder. And they have the same mechanisms of action, of disease pathology. And 19.4% of all their neurological patients with other neurological issues also showed to have exposure to it. So you can't quite say cause and effect, but they have found it, not just the antibodies, but the actual organism in a lot of these patients. So one of the ways that it can escape the immune system is it can actually go intracellularly in both fibroblasts and epithelial cells, keratinocytes, and so it hides from extracellular antibiotics that are often prescribed to treat it. So then when you have symptoms afterwards, they consider you treated and consider it psychosomatic or a new illness. So the fact that it can invade these cells and then evade antibiotics presents a huge problem with later diagnostics and treatments. This is the one where not only could they invade these endothelial cells, but they have this protein called a Cras protein, and it binds a complement factor that they have that identifies host cells as friendly. So factor H goes around and it attaches to your cells so that the complement immune system doesn't attack it. Borrelia has the ability to bind these complement factors to evade the immune system and identify itself as friendly. So several studies have found antineural antibodies in patients that used to have borreliosis. So now you'll find a lot of physicians say there is no such thing as chronic Lyme or persistent Lyme syndromes, it's psychosomatic. Well, 3 studies have found that around 50% of patients that had a disseminated infection with Borrelia burgdorferi, the causative agent of Lyme disease, had antineural antibodies. So antibodies to their own neuronal tissue, myelin basic protein. So there is evidence that this happens. And over 55% of them had MRI abnormalities, a lot of them mimicking multiple sclerosis. So this is not a psychosomatic disorder. So then it leads to, okay, if it's hard to treat with antibiotics, and a lot of these patients have these inflammatory cascades that are debilitating them, some of which can't even get out of bed. What do? So you have to look at what Lyme bacteria does. So it starts, anytime you have an infection, your body binds to that antigen and you have this inflammatory cascade, cytokines, chemokines, and it's supposed to cause inflammation in the acute term. But then later on, the immune system is supposed to make, after you clear the infection, these anti-inflammatory cytokines. Now, whenever that immune response doesn't happen, that can lead to progressive inflammation and sometimes autoimmunity. So that's what the Lyme bacteria does, is it, through nuclear factor kappa beta, interleukins, and interferon gamma, it causes this inflammatory cascade that does not go away. So, and it also JAK-STAT signaling pathway, that's just what's involved with whenever there's this inflammatory signaling or the binding of antigens, it's what takes that information, it takes it inside the cell, and then it allows for transcription to change. So how do we fix it? Well, one of the things involved with cytokines is cannabinoid receptors. So we have endocannabinoids. We make our own cannabinoids, besides the cannabinoids you would think of in marijuana and elsewhere. And they're responsible for some of this negative feedback to turn this inflammation down. So by seeing how it interacts with Borrelia, you can get an idea of, well, treatment with cannabinoids work. So one of the things that cannabinoid agonists do, ones that bind to CB2, is it reduces interferon gamma, which is increased in response to Borrelia, and suppresses that JAK-STAT signaling. And it also decreases tumor necrosis factor alpha, the nitric oxide production, which can be cytotoxic, and interferon gamma. So basically, the CB2 receptor is responsible for ameliorating all of the stuff that is seen elevated in these chronic Lyme patients, and even acute Lyme patients. This is just more suppression of interleukins and interferon gamma. So they have this mouse model for multiple sclerosis, this experimental immune encephalomyelitis. It's basically just their form of multiple sclerosis where there's an antibody introduced for myelin-basic protein. So whenever they use this and they add CBD, cannabidiol, which is a component of marijuana, a non-psychoactive component, it stopped this myelin antigen from being created. So in borreliosis, you have anti-neuronal antibodies, so it stands to logic that with CBD or a CB1 agonist, you could reduce the expression of these transcripts and this myelin antigen, and you could stop that anti-neuronal antibody production. And anandamide is one of the endogenous ligands to that, and it could be that since they're produced on demand, you see that these cannabinoid receptors are expressed more heavily in these chronic Lyme patients in MS. And it seems as if the body wants more activation events in order to deal with the excessive autoimmunity and inflammation. But since it's produced on demand and not stored in vesicles, you might need outside exogenous cannabinoids like CBD or THC, whether it be psychoactive or non-psychoactive, to stop this from happening. And also, just to add into that, they also create these these anti-ganglioside autoantibodies, and it's involved kind of in Sphingolipid metabolism. And a lot of the inflammatory reactions from that could be fixed with that cannabinoid agonism. But this anti-ganglioside activity seen in ALS, Guillain-Barré, a couple other demyelinating peripheral neuropathy type disorders. And also they've seen about half, when they look at ALS patients, like MS patients, half have antibody evidence of exposure to Lyme disease. So Sphingolipid is for multiple sclerosis, and it's active at the sphingosine 1-phosphate receptor, and what it does is it stops these lymphocytes and other cells from leaving lymph node tissues, thereby preventing the reactions from autoimmunity that cause inflammation and cell death. So that's a possible drug that could be used for these borreliosis patients. But cannabinoids, especially non-psychoactive ones, if their agonism could be that helpful in reducing these neurotoxic type of interactions, then I think there's less side effects associated with that. So in conclusion, the misconceptions need to be addressed. In order for these treatments to be elucidated and the pathogenesis to be more understood, we need to face the fact that our Lyme disease diagnostic capabilities aren't as good as we say they are. And that's hard to say because then what do? You can't do PCR testing, Western blot testing, ELISA testings as a physician and get a good clinical picture. It seems like you're just shooting in the dark, but pretending that the problem doesn't exist isn't going to help these patients. It isn't going to help research or isn't going to help anyone else. That's it. Thank you.